Welcome for another lecture in the series Surgery for Undergraduates. Today's topic is renal cell carcinoma or adenocarcinoma of the kidney.
This slide shows the general outline of the urinary system, which consists of a pair of kidneys in the upper abdomen, the ureters, which joins the kidney to the urinary bladder which is located lower down in the pelvis, followed by the urethra. Okay, the kidney is located in the upper abdomen. It is a retroperitoneal organ on either side of the vertebral column, okay, where the main arteries of the abdomen traverse. It typically extends from T12 to L3. Okay, upper end is at level of the T12 vertebra, and lower end is around T3 vertebra. And the renal pelvis, which is in the middle of the kidney, is around L1 vertebra. The right kidney is slightly lower than the left because of the liver, which is located around here. The kidney itself is made up of three parts: the cortex, in which the tubules, millions of tubules are located; then the medulla, where the collecting system is located; and the pelvis, which is the receiving or receptacle part of the kidney, which receives the urine before being transported into the renal pelvis and the ureter to be drained into the urinary bladder. The arterial supply of the kidney consists mainly from the renal artery, which arises from the aorta. And the venous drainage is through the renal vein into the inferior vena cava, on either right and left sides. The kidney itself is covered with a capsule, a fascia known as the carotis fascia, the outermost layer here, which also encloses the adjacent adrenal glands, which attaches to the upper pole of the kidney. The kidney is surrounded by this yellowish structure, which is known as the perinephric fat. Okay, this is the perinephric fat, which covers the kidney and act as a cushion to absorb the shock or some sort of all the trauma. And the kidney itself is covered with another layer of thickened area known as the capsule of the kidney. So the outer layer of wall of the kidney consists of a capsule, the perinephric fat, and the carotis fascia. This is very important when it comes to staging of tumor of the kidneys. This is the outline of the venous drainage of the kidney. Okay, as I said, the veins drain into the renal vein on the right and left side, which then carries the blood into the vena cava. Of importance is the difference between the testicular vein on the left and right side. On the right side, it drains into the vena cava directly, whereas on the left side, it enters at a right angle to the left renal vein, which carries the blood into the vena cava. This is at a right angle, and as a result, there is some degree of stasis of blood in the left testicular vein, causing a slight dilatation, and explains the reason why varicocele is more often seen on the left side. To the topic proper, renal cell carcinoma. Renal cell carcinoma, or RCC in short, is also known as renal adenocarcinoma. It arises in the epithelium of the proximal convoluted tubule of the kidneys. and is frequently detected coincidentally during some routine physical examination. There are three major subtypes: clear cell carcinoma, papillary carcinoma, and chromophobe renal cell carcinoma. And the male to female ratio is 2:1. The peak incidence is between 65 and 75 years of age, and it is uncommon before the age of 40. If present in patients less than 46, there's a high possibility of underlying hereditary kidney cancer syndrome. Among the three major subtypes, clear cell carcinoma is the most common subtype, accounting for 83 to 88% of the renal cell tumors. What are the risk factors for this cancer? Age, as mentioned, it occurs in the elderly, more common in males, 2:1. Obesity is another factor. Hypertension, cigarette smoking, and medical conditions such as chronic kidney disease, patients on hemodialysis, patients post-transplantation, renal transplantation, and acquired cysts of the kidney. Family history of RCC is also another risk factor. Underlying von Hippel-Lindau disease, which is a condition where there are multiple cysts and tumors in various organs of the body. Excessive exposure to cadmium and asbestos are considered other risk factors. And very important is non-steroidal anti-inflammatory drugs. Abuse of these drugs can also lead to renal cell carcinoma. The clinical features of renal cell carcinoma. A large majority of patients with renal cell tumors are identified only incidentally during imaging investigations. They are basically asymptomatic. Amongst the symptomatic patients, about 60% present with hematuria, 40% with loin pain, and only 25% with a mass in the loin. And only 15% of them have the triad of pain, hematuria, and a mass. Unexplained weight loss and anemia are another important diagnostic signs. Fever, raised ESR, polycythemia, disorders of coagulation, and abnormalities of plasma protein and liver function tests are also important diagnostic features. The other important symptoms to consider for renal cell carcinoma is paraneoplastic syndromes and also varicocele on the left side. Okay, what are paraneoplastic syndromes? Renal cell carcinoma is a classical example of a tumor that can produce ectopic hormone production. Okay, it is a very source of ectopic hormone production. And these hormones include erythropoietin, which will cause polycythemia, renin, cause hypertension, insulin, causing hypoglycemia and diabetes mellitus, adrenocorticotropic hormone or ACTH, which results in Cushing syndrome, parathyroid hormone leading to hypercalcemia, and increased gonadotropins production due to gynecomastia, amenorrhea in women, reduced libido, and baldness. Okay, these are the various hormones that can be produced by renal cell carcinoma, and basically with these symptoms they classically present to a physician or an endocrinologist. Hematologically, anemia is another important manifestation, and also fever of unknown origin, PUO. The investigations for renal cell carcinoma. First, a complete or full blood count, checking for signs of anemia or other abnormalities. Urine examination for the examination presence of RBC or even malignant cells. This will be followed by an abdominal and kidney ultrasound. This is to look for any abnormal lesions, masses in the kidney, enlargement of the kidney, or distortion of the calyces. If necessary, this will be followed by a CT scan to get a detailed information of any mass lesion, any presence of stone, or presence of distortion of the kidney. If there is a tumor, it can also be used for staging of the cancer itself. Bone scan, PET scan, and chest X-rays for all used for the staging if it's a cancer that is seen. Okay, this is an ultrasound picture image of the kidney is showing a large solid mass that is within the lumen or within the body of the kidney. Okay, it seems to be well encapsulated, except for these sites there's some irregularities which has to be reconfirmed with other pictures. Okay, it's a solid mass which is suggestive of renal cell carcinoma. Okay, these are CT scan pictures, okay, showing a lesion, hyperdense lesions in the lower pole of the right kidney. Again here, the tumor seems to be well encapsulated, okay, and is within the capsule of the kidney. And there are no obvious signs or changes to suggest there's enlarged lymph nodes in the para-aortic region. This one is another CT scan of another patient showing a tumor in the the upper pole of the left kidney, which is seems to be adherent or lying very closely on the left psoas muscle. Okay, here it is here very well encapsulated medially, but over here there may be some breach of the capsule here.
Next, we come to the diagnosis and staging of renal cell carcinoma. The classical triad of hematuria, loin pain, and loin mass are found only in 25% of the patients. The vast majority of them are diagnosed on incidental findings, especially incidental ultrasound for other abdominal conditions. Ultrasound, the initial investigation of choice, allows differentiation between solid tumor and simple renal cyst, whereas staging CT scan imaging with contrast enhancement of the chest, abdomen, and pelvis are very good in detecting metastasis in these areas. CT scan guided biopsy for tumors less than 3 centimeters in diameter and with no evidence of metastatic spread, and when the nature of the lesion is uncertain, then ultrasound or CT scan guided biopsy may be effectively used to avoid unnecessary nephrectomy for a benign disease. This is a simplified staging system for renal cell carcinoma using the T and M classification. Okay, T1 is a tumor that is limited to the kidney and its size is less than 7 centimeters. T2, tumor limited to the kidney, but now the size is greater than 7 centimeters. T3 is ingrowth of the tumor into the perinephric tissue, but not beyond the Gerota's fascia, or if the tumor thrombus is present in the renal vein. T4 involves ipsilateral adrenal gland involvement or invades locally beyond the Gerota's fascia. Okay, this diagram summarizes the stages of renal cell carcinoma. Okay, stage 1 is here, a small lesion less than 7 centimeters within the kidney parenchyma. Stage 2, same, it is present within the renal parenchyma, but the tumor now size is more than 7 centimeters. Stage 3, the tumor, irrespective of the size, this involves the perinephric capsule of the perinephric fat or the perinephric tissues involved. That's stage 3. Stage 4, here, it is irrespective of the size of the tumor has penetrated and breached the capsule and the Gerota's fascia, the outermost fascia here. Or it has also, if it is in the upper pole, it involves the adrenal gland. And in stage 3, the renal vein is also involved with tumor invasion. Okay. Treatment for renal cell carcinoma. The main line of treatment is surgery, which consists of 3 types: partial nephrectomy, simple nephrectomy, and radical nephrectomy. In partial nephrectomy, part of the kidney is removed. During a simple or total nephrectomy, the entire kidney is removed. In radical nephrectomy, depending on how far the disease has spread, more extensive surgery may be done to remove surrounding tissues, the lymph nodes, and the adrenal glands. Next, what treatment is radiation therapy, which can be external or internal, depending on the physician and the patient. And third one is chemotherapy, the use of IV antimitotic drugs to control the disease. The fourth mode of treatment is biological therapy, which is also known as immunotherapy, okay, which works with the immune system to attack the cancer. It boosts your body immune system to fight the cancer. The next mode is targeted therapy, which is a newer kind of cancer therapy, where drugs are used to attack and kill certain cancer cells without damaging the healthy cells. And then the last of the treatment is the use of vaccines and cytokine treatment, and also hormonal therapy. These are all in the early stages and not very widely used in most cancers. Okay, this is a picture to show you radical nephrectomy. The whole kidney is removed with the tumor. The renal artery and vein are ligated. The ureter is also removed. Okay, whole kidney with the perinephric fat is removed. Renal fascia also removed. Ureter is removed. Adrenal gland, depending on the location of the tumor. If it is in the upper pole, adrenal gland is also removed. And of course, if there are lymph adenopathy or lymph nodes are involved at the isla region, the lymph nodes are also removed. This is radical nephrectomy. Okay, another picture showing a tumor here in one of the poles of the kidney. Okay, where radical nephrectomy is done to remove the kidney perirenal fascia envelope, that is the perinephric fat, and the carotis fascia, a renal gland, and the regional lymph nodes, including the ipsilateral para-aortic lymph nodes. However, patients with tumor less than 5 centimeters located at the inferior pole of the kidney, the adrenal glands can be spared. Okay, if it's the inferior pole, the tumor is less than 5 centimeters, then the adrenal gland at the opposite pole is removed. It's spared. Okay, this diagram shows partial nephrectomy and a new way to eliminate kidney tumor and preserve the part of the kidney that is not affected by the tumor. Okay, the tumor is locally excised and then it is sutured and the wound is closed. Okay, here partial necrotomy and radical nephrectomy differences. Here locally excised and the wound is closed with sutures. Over here, the whole kidney with the carotis covering fascia is removed with the ureter, and then the renal artery and vein are ligated. Okay, what is partial nephrectomy? It's the complete removal of the primary tumor while preserving the largest possible amount of healthy renal parenchyma. This is indicated in patients with T1 tumor and normal contralateral kidney. It is strongly recommended in the following patients. First, patients with RCC who have only one kidney, anatomically or functionally. So whatever kidney you have, you need to preserve. So in these patients, partial nephrectomy is strongly recommended. The second group of patients are those with bilateral synchronous renal cell carcinoma. So you cannot remove both kidneys. So you try to preserve as much as possible by doing a partial nephrectomy on either side. And third are those with von Hippel-Lindau syndrome, which is a precursor of RCC. In these patients, whatever lesions are seen are removed by local excision, as in partial nephrectomy. Partial versus radical nephrectomy. Whenever possible, partial nephrectomy should be the preferred treatment. Compared, long-term cancer control are comparable. The cancer control by partial necrotomy is comparable to radical nephrectomy. Lesser risks are involved if in chronic renal insufficiency and proteinuria. Lastly, we come to some very conservative treatment with the radiofrequency ablation and cytotherapy for localized tumors. Alternate strategy, these are for strategies for elderly patients who are at high risk of radical nephrectomy and who are unsuitable for surgery. It is considered for patients with growth more than 3 to 4 centimeters. Completely destroy all the viable tumor tissues by this system of treatment. It's done either laparoscopically or percutaneously under CT or ultrasound guidance. The problem of this procedure, localized procedure is the high recurrence locally after ablation of these tumors. Okay, next we come to prognosis. Prognosis, again, fundamentally depends on the stage of the disease. In stage 1, the 5-year survival rate is 95%. That is when the tumor is less than 7 centimeters and confined within the kidney. It's less than 95% survival rate. In stage 2, when the tumor is more than 7 centimeters, but within the kidney, the 5-year survival rate is 88%. Stage 3, when the tumor in major veins or adrenal gland within the Gerota's fascia or regional lymph nodes are involved, the 5-year survival rate is 59%. And in stage 4, the tumor extends beyond the Gerota's fascia and the regional lymph nodes are involved, the 5-year survival rate is only around 20%. So in stage 4, it's around 20%. Stage 1 is 95%. Okay, important points to take home from this lecture on renal cell carcinoma. Approximately 1/3 of individuals with renal cell carcinoma have cancer that has spread at the time of diagnosis. The classical presentation of triad, that is of loin pain, loin mass, and hematuria, only occurs in a small proportion of the patients. The third point is patients with renal cell carcinoma must present with paraneoplastic syndromes, okay, all sorts of endocrine problems. Hematuria in these patients is classically painless and total. In a small percent of patients, in older patients, the presence of varicocele on the left side should arouse some suspicion as to the possibility of tumor involvement of the left renal vein. Vague abdominal pain, especially in the loins, must be seriously considered and ultrasound considered for this patient to rule out renal cell carcinoma. Then, once again, I have to emphasize the paraneoplastic tumor, which can present with endocrine problems, which must be referred for further investigation if necessary to rule out renal cell carcinoma. I hope this short lecture on renal cell carcinoma would have been of great help to you in understanding the topic better. For more such videos in this series, please visit my YouTube channel at this link given below. Hope to see you again in another lecture in this series. Thank you.